Can you guys hear me? Can you hear me? Okay, great. Thank you for coming. Today we are going to talk about, for this first session, we'll talk about metastasis-directed radiotherapy for oligometastatic disease and also beyond that. And here's my disclosure. I will go over the slides pretty quickly due to the time limit, but I will definitely leave some question time at the end. Feel free to ask your questions in Mandarin if you feel more comfortable doing so. So here are the objectives. I will first discuss some indications of radiotherapy for metastatic cancer and review relevant literature as well as our institutional experience. And finally, we'll outline some challenges. Okay, so we know that we have used radiation therapy for metastatic disease for a long time, right? But mainly in the palliative setting. For patients with metastatic cancers, they often go on first-line systemic therapy, and if they progress, second line, and at some point in time, they suddenly remember radiation. So they'll send the patient to us for palliation of their symptoms. However, we know that radiation can do a lot more. It can definitely palliate symptoms for airway obstruction, bleeding, pain, spinal cord compression. But radiation can also be used to prevent symptoms from occurring for pain prevention before it ever occurs. And in the setting of oligometastatic disease and other settings, radiation can possibly be used to alter the trajectory and progression of disease. So I would definitely argue that radiation therapy in the form of ablative radiation or SBRT should be integrated along every single step of their patient's treatment, not just on the sideline, but more integrated into the whole decision-making for the whole team. So let's briefly talk about oligometastases. These are the different terminologies and definitions for different quote-unquote oligo phenomenon. So you can see they are outlined here. Typically, oligometastatic disease is referred to a state that has very limited number of metastases, typically 1 to 3 or 1 to 5, but the definition is arbitrary. And there are synchronous oligometastases, meaning that the disease is detected when they are diagnosed with their primary tumor. Metagonous means that the development of oligometastatic disease occurred after the diagnosis of their primary tumor. Oligorecurrence means that there's a controlled primary tumor and somehow there's a disease popping up elsewhere. And I will also focus on oligoprogression. It's a newer terminology, means that there's limited progression of metastatic disease in otherwise pretty stable widespread disease. So there are a few oligometastatic disease trials that I'll go through pretty quickly, and I think most of you are familiar with all these trials. The first one the first one here was conducted at MD Anderson. It was focused on metastatic non-small cell lung cancer, having been stable on systemic therapy for at least few cycles, and the patient had less than or equal to 3 metastatic lesions. So that was their definition of oligometastases. You can see that when adding local therapy in the form of SBRT or surgery, so these patients actually could get surgery for their metastatic disease. The addition of local therapy improved overall survival and progression-free survival. Similarly, the SABR-COMET trial, which included various histologies, also showed that the addition of SBRT improved overall survival. And this is a study conducted in China, probably less well-known, but in a more specific lung cancer population with EGFR mutation and stable after first-line TKI. The addition of radiation therapy, again, showed improvement of overall survival and progression-free survival. And these are the similar studies in the prostate cancer area that I will actually skip through, but the slides are online for your reference. So STOMP and ORIO both were conducted in the prostate cancer patients, again showed the addition of SBRT improved biochemical failure for progression-free survival in these patients. So I want to spend a little more time talking about NRG-BR002. This study was presented last year but has not yet been published. This was the first study looking at SBRT in oligometastatic breast cancer patients. So as I mentioned before, the previous studies focused on either a mixture of histologies or non-small cell lung cancer. So this was the first one conducted in the breast cancer patients. Patients had 1 to 4 metastases. That was their definition. And there's a mixture of ER positive and negative patients. They were randomized to standard of care, hormone therapy, or other systemic therapy, versus the addition of SBRT. So you can see that in their analysis, there was no difference in the progression-free survival or overall survival with the limited follow-up with the addition of SBRT. So this was first one big negative trial in this, the space of oligometastatic disease with the addition of SBRT. Interestingly, all these breast cancer patients, for them, a lot of them actually developed new disease, new sites of metastases that were not previously detected when they had the progression. So there are several ongoing oligometastatic disease randomized clinical trials with single histology or mixed histologies. So we're waiting for more data to come out. And I'll talk about the implication of some negative trials later. But I want to switch to oligoprogression first, because this is not as discussed, but I think it would be very interesting. So what is oligoprogression? When we define oligometastases, it's already challenging in that there's various definitions of 1 to 3 sites or 1 to 5 sites of metastases. But when we talk about oligoprogression, it's even more challenging. There is no standard definition, and many attempts to define this phenomenon is solely based on the clinical scenario, not on the biology of disease. But in general, this is how we can picture oligoprogression. So imagine you have a patient who presented with 3 sites of tumor, and then the patient went on to get systemic therapy. And then initially, most patients could respond. All sites of disease shrunk after a period of systemic therapy. However, when you continue to give systemic therapy, some of the tumors eventually would progress. In this situation, there's only one lesion that progressed. The other 2 remain stable. So that's the situation that typically we call oligoprogression. When we face oligoprogression, what do? There's really no standard answer. So many medical oncologists will say, oh, we can switch to the next line systemic therapy. But if there's only small progression, most people will actually continue treating past progression and then see how people do. Sometimes people will add another line of drug in addition to the current systemic therapy. So there's really no specific defined answer for managing oligoprogressive disease. So here is a more common definition. So in summary, oligoprogressive disease is a relatively new concept. It means progression at only a few sites of metastases in patients with otherwise controlled widespread disease. As I mentioned, what is the management for oligoprogressive disease? It's different. So for example, in the non-small cell lung cancer patients, when they progressed on the first-line systemic therapy, if they were PD-L1 positive, they were typically put on pembrolizumab based on the KEYNOTE-010 data. For patients with EGFR mutation after first-line TKI, and they will switch to a different TKI with limited progression-free survival benefit. After the second-line TKI, there's really no standard treatment for these patients. For breast cancer patients, especially for the triple-negative breast cancer patients, after their first-line chemotherapy, there's no standard of care. And the progression-free survival with subsequent drugs are actually very limited. There are several retrospective series looking at what we could potentially do with addition of radiotherapy in the patient with oligoprogressive disease. If we give them radiation to the limited sites of progression, would that help the patient? There are 4 ongoing and recently finished randomized clinical trials of oligoprogression, and I will talk more of them in detail. The first trial in Canada, it was just actually closed last year. This is a patient population initially for non-small cell lung cancer only, but later because of challenging accrual, they opened the study to all histologies. There were patients with up to 5 oligoprogressive lesions after systemic therapy. So I want to emphasize that they can have up to 5 progressive lesions, but they can have more than 5 stable lesions that are not progressing. So these are not oligomet patients. They have more disease and more unstable disease than the oligomet patients. So this patient cohort, they were randomized 1:2 to the addition of SBRT to the progressive sites only. The stable sites were not treated versus standard of care. So you will see the results being presented in this year's ASTRO late breaking. The whole trial is more specific for TKI mutated lung cancer patients with progression on first-line TKI, again, randomized to the addition of SBRT to the progressive lesions versus not. This is still ongoing. The SUPPRESS trial conducted in Canada is also ongoing, focusing on non-small cell lung cancer plus-minus driver mutation and still accruing right now. So I want to spend a little more time talking about the CURB trial that we did back at MSK, Memorial Sloan Kettering. It is a similar design compared to the STOP trial led by David Palma, in that there are patients with non-small cell lung cancer, but we also added breast cancer patients with less than or equal to 5 oligoprogressive lesions. Again, they can have more than 5 total lesions. They were stratified based on these factors and randomized to either the addition of SBRT to the progressive sites versus the continuation or switching systemic therapy per the physician's choice. And the trial was opened in 2019 with an accrual goal of 160. We did an interim analysis after 106 patients, and because of efficacy, that we closed the trial. So we wanted to see if the addition of SBRT to the progressive lesions will improve the progression-free survival. That was our primary endpoint. And this is the study timeline. We register the patient and we take serial follow-up scans up to 1 year. So at the time of interim analysis, we had 106 patients, a little fewer breast cancer patients, and then the non-small cell lung cancer patients. And this is the distribution of the total number of metastases. You can see that for the breast patients, about 50% of them had more than 5 total, not just not the progressive site, but total sites. So these are much sicker patients. And also about 1/3 of lung cancer patients also had more than 5 lesions. And then this is the distribution of their different sites of metastases. So when we look at the progression-free survival as a whole, combining breast and lung cancer patients, the addition of SBRT greatly improved their progression-free survival by more than 2-folds, with a median follow-up of 1 year. Strikingly, when we did a subgroup analysis, we could see that the benefit actually was entirely driven by the lung cancer patients, with more than 4-fold, 4 times the difference of the benefit with the addition of SBRT, but there was no difference at all in the breast cancer. So this mirrors the NRG-BR002 results, although in a different population. So first, I want to actually, before I go on, I want to illustrate the possible patterns of further progression after the initial oligoprogression, because the concept can be a little confusing. So you see that this is a patient with a lot of different sites of disease. After chemo or systemic therapy, had the red dots are the not responding lesions. They are progressing. The green dots all responded. So that's the definition of oligoprogression that we used. Then this patient is randomized to SBRT versus no SBRT. So the SBRT was only targeting the progressive sites, not the green ones. And then after SBRT, these patients are followed. So there are several possible routes that they can develop further. So after the red dots are eliminated, the patient has stable disease. The green dots did not progress. So that's one stable disease patient. These two are progressive patients, but they can progress differently. They can progress in the untreated green dots. They just continue to grow. Or they can progress by growing new lesions. So there are different patterns of progression in the SBRT arm. In the non-SBRT arm, again, the patient didn't get any radiation at all, right? So their stable disease means that whatever they had there, they are not growing. So that's their stable disease. Or they can progress in the untreated lesions because the red dots were not treated. So they could progress in the red and green. They could also progress by growing new lesions. So these are their progression patterns. When we look at the progression patterns of the breast and lung cohort by their SBRT arm, these are the relative percentage, so not absolute. You can see that for most breast cancer patients, they grew new disease that's not previously there. Whereas in the lung cancer patients, they progressed if they were not randomized to SBRT. So the red disease progressed. The green one, the previously green one, they were stable. So this is actually consistent with previous result by the NRG-BR002, indicating that the breast cancer patients may not have the true oligo phenomenon. They may be more systemic because they were growing new disease at each follow-up. So maybe we just didn't detect their disease at all when they were enrolled in the study. We also did a liquid biopsy at the time of baseline and also at their follow-up. And we used the in-house assay to detect the mutational patterns of the disease pre and post-treatment. So I'll skip the background. But I want to show this data. So when we compare, so this is a fold change. So we compare the after divided by before, looking at the mutational burdens. So for the SBRT and non-SBRT group in the breast cancer, the after the DNA mutation patterns after treatment divided by before, if there's no change, that's 1, right? Because there's no different folds change. So you can see that for most patients, regardless of SBRT, there's no change in their mutational pattern because they're still growing new disease. And even if we SBRT the so-called oligoprogression, it doesn't matter because new disease keep popping up and they continue to generate tumors. Whereas in the lung group, when they had SBRT, the mutational tumor burden decreased post-treatment. Compared to the no SBRT, they continue to progress. So this biology, the correlation actually, further confirmed our suspicion that in the breast cancer patients, at least in the cohort that we treated, they were more systemic. Radiation probably wasn't going to be useful. So whether the breast cancer patient, they don't even have an oligoprogressive state, or they don't have oligometastatic state, or we didn't capture them at the right time for our intervention, this remains to be answered. So there are many, many unanswered questions. As I mentioned before, should we continue a phase 3 trial? Should we define a different patient population to capture them better? What is the endpoint? Do we want to study overall survival or progression-free survival? And there are even more unanswered questions, as I mentioned. Is there any oligoprogression state or oligometastatic disease state in some cancers? Some breast medical oncologists actually had previously made a statement that there's no oligometastasis in breast. Breast is more systemic. That was before any of the oligomet study was done. So is this true? Or are we just not really selecting the right patient population? So we will really need more studies to answer these questions. Or maybe our definition by counting the numbers of tumors is not great. We need some better definitions based on the tumor biology and other factors. So I'm going to go over a couple of cases for practical considerations and few patients treated on the trials. So this is an oligoprogressive case that we treated on the trial. And this is the patient that first presented in the initial staging. You can see that the patient with non-small cell lung cancer with diffuse metastatic mediastinal lymph node and left lung mass. In addition, with metastases to the parotid, this vocal cord is paralyzed. The left vocal cord was paralyzed. The right was hypermobile because of the tumor in the mediastinum, not the metastases. And then the patient also had different bone metastases. So this is not your oligometastasis patient, right? It's very diffuse. So the patient went on to start pembrolizumab with carbo and paclitaxel. So first-line chemoimmunotherapy. And after 2 months, the PET scan showed partial response. The lung disease actually responded very well, and other sites were stable. So the patient continued to go on pembrolizumab and chemotherapy. 2 months later, another restaging restaging scan was done. However, it showed increased 3 spots in the previously FDG-avid bone mets. They were all increased in size and FDG avidity. So this patient was consented to the oligoprogression trial, and she was randomized to the SBRT arm. So the patient received SBRT 30 gray in 3 fractions to these 3 bone lesions only. We didn't treat the lung lesions because the lung lesions were stable and still responding. So SBRT 30 gray in 3 fractions, 3 isocenters with a lower body mode in 1 setup, 3 different isos. Treat 1 fraction daily during the off week of chemo IO because the patient is still getting chemoimmunotherapy every 3 weeks. So we just chose to get the radiation done during their break. After that, patient continued to get chemoimmunotherapy, and then after a while, just the maintenance immunotherapy. The patient remained progression-free. The lung disease continued to be stable or responding. The bone disease that we were treated didn't progress, and there was no disease that popped up. So this was one of the stable patients after being randomized to SBRT. So another practical consideration is that many people would ask, if the patients are on certain new drugs, how long should we hold the drugs? If they're on VEGF inhibitor or other newer CDK inhibitor, how long the break should be. This is a very good summary written by one of our fellows at Princess Margaret, reviewing current literature and coming up with a few suggestive guidelines, suggestive management options for these patients, because we know that there's really no definitive evidence of how long we should hold certain drugs before radiation. So I think this is a very useful tool that everyone can look up. This is published at Advances in Radiation Oncology. It's free, it's open access, so everyone can download the article and the table. I find this very useful. Right. So the last few minutes, I want to talk about our multidisciplinary metastatic disease program and how we established the program to help managing patients with metastatic disease and also to run the trials. So the first program was actually started back when we were still at Memorial Sloan Kettering. It was in 2016, and we established a multidisciplinary metastatic disease management radiation program to really see these patients and to focus on their clinical care as well as research. So as we all know, that as radiation oncologists, we are defined by our disease sites, right? So I'm a head and neck radiation oncologist, I'm a GU radiation oncologist, but we at Memorial Sloan Kettering, we also had a metastatic disease radiation program to really capture all patients in different phases of metastases, because the treatment of metastasis, as I said, it's evolving. It's not just 8-grade times 1 anymore. Sometimes we use very higher dose, and sometimes we use it in conjunction with newer therapies, or we enroll them on trials. So having the program will really help us manage all different aspects of the patient's care. And also with this metastatic disease team, we can actually, as I said, accrue these patients in different trials, because the trials are usually not just one single histology. It can be across different histologies, so I find it very useful. In addition to the CURB trial that I mentioned, these are additional trials that the metastatic disease program has done and been successful. At Princess Margaret, we also have a palliative radiotherapy oligometastasis program. It was initially established in 1997 and later on integrated the oligometastatic disease component into the patient care. The goal of the program is really to provide, again, rapid care, that when patient comes in for consultation, we give them same-day simulation, same-day treatment. Everything is done within a few hours so that the patient doesn't suffer and can get a palliation. We are now moving forward to eliminate CT simulation in some of these patients, meaning that we use their diagnostic CT scan that they already had as our simulation scan. So when they come in, we already have a plan for them. We can move them to the CT simulator, do a verification sim, and deliver same-day SBRT. So that's something that we're working on right now, and that will even facilitate the patient's care a lot more. With the involvement of radiation in addition to palliative care and prevention, we also want to improve the technology use. So right now we have a trial looking at smart T-shirt that will monitor the patient's heart rate and vital signs, because you know a lot of patients come from very far away. After their palliative treatment, they go home and they probably never come back, and we don't know how they're doing. So the T-shirt, that if they are willing to enroll in the study, they wear the T-shirt a few hours per week, and their vital signs and their temperature, heart rate are monitored remotely by the T-shirt, and the T-shirt can transmit the data to our database, so we know how these patients are doing after their treatment. And then these are other initiatives that we are working on right now as part of our palliative oligomet program. Finally, education and outreach is a huge component at Princess Margaret. We have fellows coming for our fellowship in palliative and oligomet program from all over the world. So looking forward, there are several ways to improve radiation usage in patients with metastatic cancer or oligometastatic cancer, by involving more clinical trials, increasing the utilization of palliative radiation therapy, and also looking at educating patients and as well as colleagues about referring these patients to us before they get too sick. As I mentioned before, this is the elimination of CT simulation effort that we are looking to develop right now. You can see that the usual workflow when we see a palliative care patient include consultation and a book of simulation, treatment planning, and physics QA, and then treatment. So the treatment can happen in actually in the same day, but usually it's more like a 2D, 3D planning or simple IMRT. For some patients requiring SBRT, usually they cannot be delivered the same day. At fastest, we can do the next day SBRT, but not the same day. But for Princess Margaret, because some patients actually travel 5 hours away to go to the tertiary cancer center. Having to have them come back the next day is not practical. Therefore, if we use the diagnostic CT and pre-plan the radiation, so when we see them for consultation, we just need to do the verification simulation, and then we can do the treatment. So everything can be done the same day, and this is led by our lead radiation therapist that we are hoping to roll out. As I mentioned before, we use the Smart Shirt to record patient vitals. This Smart Shirt was actually initially being used in NASA to monitor the astronauts' heart rate and vital signs. So we work with this company to use the same technology to help monitoring the patient remotely and to decrease their travel. In addition, as part of the palliative component, we often get asked, especially after SBRT to the bones, how much can they exercise, right? Can they lift weight? Should they do rehab? Or how much weight they can lift, or they shouldn't do any activities at all? There's actually no right answer to this. But I think it's very important because as an overall quality of life improvement, patients want to continue being active. So we partner with our physiatry program to run a randomized clinical trial of regimented exercise program in patients who receive SBRT for their bone mets and see if they can improve the patient's outcome and overall quality of life. And this is led by one of our junior radiation oncologists. And in addition, as I mentioned before, collecting blood samples for genetic analysis is very important to study the biology. So in the province of Ontario, we have an Ontario-wide cancer-targeted nucleic acid evaluation. The program collects blood and tissue from our cancer patients to be analyzed by various different assays. So as part of our palliative and oligomet program, we partner with this genome-wide analysis initiative to collect and analyze patients being treated with radiation before and after for various indications listed here. And I think that will give us a better idea of how some patients eventually progressed after SBRT and whether we can select the patients better for future treatment. In the last couple of minutes, I want to talk about the design of clinical trials. As I mentioned before, there are many positive clinical trials of oligometastases and oligoprogression, but we also have a few negative trials. I think it boils down to the definition of oligocancers because, as I mentioned before, there's really no universal definition, and the definition based on clinical factors counting the numbers may not be adequate. We probably need to know more about the patient's history in the treatment, how they develop resistance from their first-line treatment, and be more disease-specific in our design so that we can capture these patients better. In conclusion, radiation therapy can be an essential treatment for patients with metastatic cancer, not only for palliating symptoms, but also for providing durable disease control. The definition of the metastatic state based solely on imaging and clinical features is no longer completely adequate. We need the tumor biology at that point that we want to give them intervention is very crucial for patient selection. And the early molecular response detected by liquid biopsy after local therapy can be a useful guideline for our risk stratification. And last but not least, I think it's very important to determine the point of futility, because I know we want to treat patients. Sometimes the treatment doesn't help at all. So we want to know where we stop the treatment so that we can avoid unnecessary interventions. And on behalf of the entire program at Princess Margaret, I want to thank everyone here for the opportunity to share our experience. Thank you. And I'll leave time for questions.
Hello, Dr. Jillian Tsai, and I'm Dr. Yang from National Taiwan University Hospital. Actually, it's the second time I heard your talk about the oligomets, and it comes more question about this. And I have two questions. The first is in the BR002 and your CURVE trial, we both found that breast cancer didn't benefit from the SBRT treatment. But in your trial, you enroll patients with ER-positive high-risk patient and also TNBC. Do you observe the difference between these two types of breast cancer subtypes? And my second question is about the SBRT timing. Because in your trial about the oligoprogression and in the earlier trial conducted by Timmerman, consolidative SBRT is used after the primary systemic treatment. But in the SINDAS trial, the TRINA trial, they use upfront the first line SBRT to treat patients. So do you think the SBRT timing will change the result? And thank you.
Yeah, great questions. Yes, thank you. So first question, is there any difference between the triple negative versus non-triple negative breast cancer patients in terms of their response? There are limited numbers of patients here, but no, there's no difference in their response, triple negative or not. They all do actually very poorly, but I know the number of patients are limited, so we can't really draw any conclusion from that. Second, the timing of radiation. Let me see. So you are correct that the SINDAS trial actually started giving patients when they are upfront versus other trials after first-line treatment. So I think, the timing hasn't been studied at all. For the BR002, it was also done after they were stable on their systemic therapy. So it really depends on, I think if you give the radiation after a period of stabilization on systemic therapy, I think there is more selection by the drug on how the patient's tumor behaves. So rather than the upfront treatment of SBRT. So in my mind, these different types of designs are answering different questions. By giving upfront SBRT to all sites of metastases, you are really assuming that these are the only sites of tumors that are present at the time when you enroll the patients, and you are eliminating them, the gross disease, and you add systemic therapy to control the microscopic disease, right? And then, but if you give the systemic therapy upfront, then you are actually consolidating the response. So you assume that you are only taking people that responded to the systemic therapy first. So I think there are just different populations. I think they both can be studied, but they have to be timed correctly. For the CURVE trial, I believe all the breast cancer patients enter the trial too late. If you look at their median lines of systemic therapy, it's 2 or 3. So the tumors were already being heavily selected by the prior treatment and became heterogeneous in their response and mutation burdens. So that's why we didn't see any benefit of adding SBRT. So we probably have to have select them much earlier.
Thank you for your response. And our own experience is similar. The breast oncologists didn't believe the oligometastatic disease. And in the thoracic oncology, it's quite different because if the oligometastatic disease diagnosed at first and with small brain mets, then prefer upfront SBRT. But if the oligomets is on the bone or the adrenal gland, maybe they prefer upfront systemic therapy followed by the local treatment. So I think the mets side it matters as well, but not answered by the current clinical trial. Thank you.
That's correct. Thank you. We are running. Do we have another question? I think we can take one question. Yes.
Thank you. I would like to ask about the SINDAS trial. Can you go back to the last slide?
Yes.
Does INDUS trial have overall survival curve and progression-free survival curve flat in the first 12 months? Do you have any thoughts about this?
You know, I think it's because they were actually, these patients were accrued way earlier in their disease management. So as previously mentioned, they were diagnosed and then immediately accrued. So these were the patients that were not previously selected. So I think that's why this curve didn't separate. But that's just my guess, because they were just earlier. So there is a lead time, you know, when you accrue the patient, and they were just diagnosed. So they needed more time to develop events down the road. Yeah, no, that, you know, but the first, they were saying that the first here, yeah, because I think they're, yeah, so, right.
Recruit earlier, and then they cannot progress before randomization. So essentially all the patients.
They were, yeah, that's correct, yeah.
So there's already
Yeah. All right, thank you guys. Feel free to ask more questions later privately.